So my name is Lisa Peterson. I am the manager for specialized geriatric services with St. Joseph's Care Group, and I'll be the moderator for today's session. So on behalf of Northwestern Ontario Behavioural Supports Ontario, St. Joseph's Care Group, and the Centre for Education on Aging and Health, I would like to welcome all of you to this. I know it's going to be a very informative and very interesting, I'm sure, too. I know if anyone has heard Dr. St. Pierre talk, his presentations are always great to listen to. So this topic today that you're here is for personality disorders in the older adult. We are delighted again I'd like to introduce you to Dr. Edouard St. Pierre, our speaker today. So Dr. St. Pierre is a clinical psychologist, and he attained his PhD here at Lakehead University with a master's level specialization in gerontology. He joined St. Joseph's Care Group in 2006, and shortly after that, he started working in the seniors' mental health programs. Dr. St. Pierre considers himself a scientist practitioner and has had previous experience in forensics and in correctional settings, as well as long-term psychiatric rehabilitation. So for those who were on the call earlier, so Dr. St. Pierre has stated he has about a 45-minute presentation, and that's going to leave us about 15 minutes for questions. You are welcome, as he stated, you're welcome to kind of raise your hand, and if you have a question throughout the presentation, and you can, we will allow you to unmute yourselves and ask your question, or you can include it in the chat. So at the very bottom, you can click chat, and your chat box will show up here on the side. As long as you are sending. You can send your chat to everyone, your question to everyone, or you can send it to myself or Allison Denton if you want to just send something privately. And we'll be moderating those questions for Dr. St. Pierre. This, as stated, this presentation is recorded, and everyone will have the link to the presentation, which will be a YouTube link. And after today's session, you'll have that. Any questions that we don't get to today, we'll definitely endeavor to have Dr. St. Pierre answer those, and we'll send them out to everyone on this call. So just a reminder to please keep yourselves on mute. If you can use the raise hand option, that's great to be able to, or raise your hand up if you have your camera on, we'll see. And if you have a question, again, feel free to put it in the chat box. Also, we encourage you to add in the chat box any future suggestions for education. We like to keep going with these learning series in the fall time. So if you have any suggestions, feel free to include them in the chat. You'll also, at the end of this presentation, have a 3-question poll. And so we'll like you to complete that once the session is over. So I will pass it on to Dr. St. Pierre.
Thank you, Lisa. Thanks, everyone. Thank you for attending. I hope I can live up to my own reputation. It's sort of intimidating. Okay, so I'll do the share screen here. Okay, good. So we're going to be talking about personality disorders in older adulthood. Brief outline there that I'll let you digest on your own. I'll be reading to you enough already today, so let's get to it. All right, defining personality disorder. We're going to go a little quick through this, at least through the categorical model that the DSM-5 uses, based on the assumption that most people, or a lot of people, will be familiar at least with the basic definition of personality disorder, and or have the ability to read into it a little deeper on their own when they'd like to. Okay, so what is a personality disorder? Well, it's an enduring pattern of inner experience and behavior that deviates markedly from the expectations of the individual's culture. This pattern is manifested in 2 or more of the following areas. So pay attention here to the fact that it's an enduring pattern. Okay, so cognition. So it's expected that a personality disorder will somehow distort a person's cognition. right? So how a person perceives and interprets the self, other people, and events. It's assumed that a personality disorder will affect someone's affectivity or their emotional responses. So the range, intensity, lability, and appropriateness of emotional responses will become dysfunctional. Interpersonal functioning is affected. The person is failing to sustain healthy relationships and impulse control. In personality disorders, we find that people are often highly overly disinhibited. Continuing just with the basic DSM-5 description here, we'll go quick through these. It is an enduring pattern, and it's expected that it is inflexible and pervasive. So this should be noted in all areas of a person's life. It is not in particular relationships, it is in all of their relationships. The enduring pattern leads to clinically significant distress or impairment. So it's not enough to say that, you know, I'm a bit OCPD, or sometimes he is a bit histrionic. You might be referring to the fact that a person has some traits of a disorder, but unless it is causing clinically significant distress in their life, we can't really consider it an actual disorder. Okay. The pattern is stable and of long duration. So this is this enduring pattern again, and it can be traced back to at least adolescence or early adulthood. Okay, and of course, with every disorder in the DSM, the enduring pattern is not better explained as the manifestation of another mental disorder, and it is not attributable to the physiological effects of a substance or another medical condition, such as a head trauma, for example. So the personality disorders. First, we have cluster A. So again, we're going to talk about a different approach to diagnosing personality disorders. So I keep pointing out that right now we're talking about the categorical model of personality disorders. So the first category, they group them into clusters, not based on any real research or anything, just based on sort of an expert consensus of which ones seem to group together because they have similar underlying symptoms. So the first cluster is cluster A, odd or eccentric. So in this cluster, we have paranoid personality disorder, which is a pattern of distrust, suspiciousness such that others' motives are interpreted as malevolent. These people fear everybody. These people think everyone is out to get them, you know, to greater or lesser extents. People are conspiring against them. The two people talking at the table at the other end of the cafeteria might be talking about them. Okay. Schizoid personality disorder. It's a pattern of detachment from social relationships and a restricted range of emotional expression. No real relationship here to schizophrenia. Schizoid is just referring to the fact that it's this pattern of detachment. These people are cold and unfeeling. They don't desire relationships. They don't feel lonely. Schizotypal personality disorder is a pattern of acute discomfort in close relationships, cognitive or perceptual distortions, and eccentricities of behavior. These people are odd. They are eccentric. And we'll talk about that a bit again later. Cluster B, the dramatic, emotional, or erratic personality disorders. These are arguably probably the most disruptive of the personality disorders. The first one, antisocial personality disorder, is a pattern of disregard for and violation of the rights of others. These are criminals, and not always criminals, but these are people who don't have a high regard for getting along with others, don't have a great concern for others, and so on. Borderline personality disorder is a pattern of instability in interpersonal relationships, self-image and affects, and marked impulsivity. Histrionic is a pattern of excessive emotionality and attention seeking. And finally, narcissistic personality disorder is a pattern of grandiosity, need for admiration, and lack of empathy. People would say that Donald Trump might be a classic narcissistic personality disorder. Cluster C, anxious and fearful. So in this category, we have avoidant personality disorder. So it's a pattern of social inhibition, feelings of inadequacy, and hypersensitivity to negative evaluation. Dependent personality is a pattern of submissive and clinging behavior related to an excessive need to be taken care of. And finally, obsessive compulsive personality disorder is a pattern of preoccupation with orderliness, perfectionism, and control. All right, so continuing on. So what is a personality disorder? The DSM-5 did propose an alternative way of diagnosing personalities, and it's an emerging sort of idea coming from basically personality trait research. If you've ever heard of the 5-factor model, it was borrowed loosely from that, loosely or not so loosely. There's still ongoing debate about how many factors there are. But the DSM, the authors of the last version, incorporated it as an alternative method. And it could be the way of the future, sort of trying to circumvent some of the problems of the classic sort of categorical approach. So under this approach, probably oversimplifying it here a bit, but personality disorders manifest as a result of a person's development and possession of extreme and rigid personality traits that disrupt healthy personality functioning. Okay, so the assumption here is that it's not just about individual symptoms that we look at in the categorical approach, but rather that the person possesses traits. They have traits that are shared by all people. It's just that the difference is in personality disorder, those common traits are extreme and rigid. Okay, and they affect this healthy personality functioning. Okay, and so something that's rare for the DSM, they actually outline for us what would be expected to be healthy personality functioning. So let's take a look at that. So there's 4 components to what is presumably healthy personality functioning. The first one is self-identity. So a healthy person experiences oneself as unique with clear boundaries between the self and others. A healthy person has a stable sense of self-esteem and can accurately self-appraise. Healthy people have a capacity for and ability to regulate a range of emotional experiences. Healthy people have self-direction. So a healthy person pursues coherent and meaningful short and long-term goals. They possess constructive and pro-social internal standards of behavior. They have the ability to self-reflect productively. If you've ever done any reading on or research into theories of wisdom, you will see there's great overlap here. When they try to define wisdom, we see pretty much very common language. Healthy people have interpersonal empathy. So a healthy person can comprehend and appreciate the experiences and motivations of others. They can tolerate differing perspectives. They understand the effects of their behavior on other people. And finally, interpersonal intimacy. A healthy person desires and has a capacity for sustained closeness to other people. A healthy person demonstrates a capacity to interact in mutually satisfying ways with other people. So certainly it's unlikely that all people or even most of us would reach the pinnacle of all these things, but this is an ideal. This is the ideal or healthy personality functioning. Okay. So the personality trait approach then says, okay, so we've got this normal, like what we would think is normal or healthy personality functioning. And so on what dimensions do disordered people, personality disordered people, on what dimensions do they seem to have troubles? Okay, and there's 5. So the first one is negative affectivity. So personality disordered people are prone to high levels of negative affectivity. Right? So essentially they're prone to frequent and overly intense experience of negative emotions, such as anxiety, depression, guilt, shame, worry, and anger. This sort of lack of, or this intense negative affectivity is most evident in borderline, avoidant, obsessive compulsive, and dependent personality disorders. Okay, not every personality disorder will load on each of these dimensions. They'll sort of load to different extents on each dimension. Second dimension, detachment. So personality disordered people are prone to high levels of detachment. People high in detachment lack a desire for and avoid emotionally meaningful interpersonal experiences. They present as cold and unfeeling. They suffer persistent low moods. They are suspicious of others. This is evident in avoidant, obsessive compulsive, schizotypal, schizoid, paranoid, and so on. The idea in the personality trait approach is that you meet someone and you can get a sense quickly, like through their behaviors, that that they are extreme and rigid. And then you can start to quantify, okay, on what dimensions are they extreme and rigid? Is it, is it negative affectivity? Is it detachment, and so on? And so the idea behind that type of diagnosis is you sort of maybe in a sense rate them on these dimensions, and it gives you a sense or points you towards which disorder it might be. It also helps quantify it. In the categorical approach, a person either is or is not, does or does not have that disorder. From the trait approach, it's more of a dimensional idea that you could say that they're very disordered, or they just have some extreme traits. Antagonism. So these people maintain an exaggerated sense of self-importance and often expect special treatment. They are callous about the feelings and needs of others. They're often dishonest and manipulative. Okay, so we see this in those cluster B, especially antisocial, borderline, narcissistic, okay, and paranoid. Personality disorder people are prone to high levels of disinhibition, okay, as opposed to conscientiousness. So these people are impulsive and focused on immediate gratification. They're prone to risky behavior. They are irresponsible and undependable. They lack follow-through on long-term goals. However, at the other end of this extreme, these people are overly conscientious and hence hyper-focused on perfectionism. So that would be that obsessive compulsive personality disorder. Obsessive compulsive disordered people are extremely focused on perfectionism and rules and things like that. It makes them extremely rigid, but in the domain of conscientiousness. On the other dimension, you have people who would be antisocial, who lack conscientiousness or concern. And finally, psychoticism. So this is where we're drifting into this domain of like being a bit delusional or losing touch with reality. So these people present as eccentric in their behaviors and thoughts. They might think they have unusual abilities, for example, mind reading or telekinesis. They report having had unusual experiences, for example, out-of-body experiences. They often maintain an eccentric appearance, their clothing, grooming, etc. Okay. We don't expect these people at all times to be drifted into like bizarre psychoticism. When a person's ideas become highly bizarre and have a much more pervasive effect over their life, then you're looking at something more like schizophrenia or another psychotic disorder. But in personality functioning, we would describe it as schizotypal. I'm not up on the most recent research on schizotypal, but there is some idea that people with schizotypal PD can at times in their life drift into this range of probably meeting criteria for schizophrenia. Maybe when they're under severe stress, etc., their symptoms might become more pronounced. All right, so let's move on. Part two, do a review here. So what do we know about personality disorders in older adults? By the way, if anyone is absolutely captivated by how nice and fancy my slides are, you can private message me later and I'll send you some pointers, okay? Personality disorders in older adulthood, what do we know? Well, we don't know a lot. There's been little research done on personality disorders in older adults. Why? Well, it just hasn't been in style yet. Research tends to have fashions, and this one just hasn't been fashionable yet. However, I have noticed in the last few years, there seems to be an increasing number of review articles and things coming out. But in general, there's been a lack of clinical interest. And maybe fairly, it's difficult when you're doing research. Well, two things can happen. If you're a graduate student or an undergrad trying to get your thesis done, the worst thing you could do is pick a topic about which it is hard to get a sample. Okay, so what typically happens is researchers use convenience samples, which tend to be university students. And so we know a lot about the personality disorders of younger adults, but a lot less about the personality disorder experience of older adults. So what do we know? Well, let's talk about prevalence. The prevalence of having at least one personality disorder among older adults is 8%, 10% in younger adults. Okay, and you could make some guesses as to why the drop, right? Well, essentially in short terms, it can be dangerous to have a personality disorder. Personality disordered people, on average, have shorter lifespans than people without personality disorders. Prevalence rates among older people receiving outpatient mental health care is estimated to be as high as 33%. The prevalence rates among older people receiving inpatient mental health care is estimated to be as high as 80%. So there's probably some people watching the talk today that can maybe agree or maybe disagree with that, but if you work in those areas, you've probably seen it. Again, the fact that 80% of people receiving inpatient mental health care might meet criteria for personality disorder doesn't mean that's necessarily why they're in the hospital to begin with. It's just that personality disorders are highly comorbid with other disorders, both medical and psychological. Obsessive compulsive personality disorder is the most frequently diagnosed personality disorder among older adults, and this is the same as younger adults. And PDs, or personality disorders in older adults, as is the case with younger adults, are highly associated with poor medical health and other mental health disorders. So what do we know about the stability of personality disorders? Remember, the definition of personality disorder requires some idea here that it is enduring, that it starts in early adulthood or adolescence and endures. So it's expected that personality, or even normal personality, should be somewhat stable. But of course, there's environmental input into our personality, and so there is some evidence for slight drift over time. So what do we know about the stability of it in older adults? Well, there's evidence that the traits associated with the cluster B personality disorders, like borderline, antisocial, narcissistic, histrionic, decline and are less prevalent in older samples compared to younger samples. So what's going on? Well, in the literature, they'll call it mellowing and burnout. Okay, so there's an age-related reduction in these dramatic behaviors, such as impulsivity, promiscuity, and fighting. So this is like a mellowing effect. As people get older, maybe someone who, in their 30s was highly antisocial or really was presenting with severe borderline type presentation. As they age, there seems to be a mellowing effect of this. It starts to back off a bit. There's age-related cognitive and physical changes can impose a reduction in dissocial activity. Maybe you start drinking less because of other health conditions, like the antisocial people. Maybe they're not out and about as much. They're not going to be identified. So there's a mellowing effect there. And finally, I guess what we would call burnout. Like I said earlier, it's sort of dangerous to have a personality disorder. They have, because of death due to suicide, murder, accident, comorbid health issues caused by poor lifestyle choices are all higher in people with these cluster B personality disorders. And so they tend to burn out. They do not live as long as other people on average. Okay, still stability of personality disorders. There's also evidence that personality disorder can appear or worsen in later life. Appear there, obviously in quotes, because it's chances are it has always been there. It's just something has exacerbated it. And so this is the most confusing name for this ever, and I made it up. Sorry about that. But essentially, we can call it environmental exacerbation of subclinical symptoms of PD. So it could be the case that somebody who has always had some degree of disordered personality traits, but was fortunate enough to live in a very stable environment, then their expression of the personality disorder never really came to fruition. It never really blossomed, or was always sort of suppressed by this stabilizing environment. But then through some misfortune in life, perhaps the death of a supportive spouse, retirement, so they had a job that provided stability in their life, or perhaps they've experienced some degree of cognitive decline, those symptoms, those subclinical symptoms become exacerbated. All right, do older personality disordered adults have an increased risk of becoming socially isolated? Yes, people with cluster A and cluster C PDs have smaller social support networks, which will only shrink as they age, leaving them with little social support in times of need. Probably, and when I say probably, I mean The research doesn't say it for sure, but we can sort of deduce it based on other correlations. So PDs are associated with impaired social functioning and increased interpersonal conflict. And so therefore we would expect that they are at increased risk of becoming socially isolated. Again, probably people with cluster B easily make new friends, but lack an ability to sustain friendships. They make good first impressions, but they become increasingly disruptive and irritating with repeated exposure and therefore drive people away from them. And probably, lastly, having any personality disorder is associated with an increased risk of marital discord and divorce in younger people, and therefore may result in social isolation later in life. Do older personality disordered adults have an increased risk of suffering elder abuse? Potentially. Personality disorders predict social isolation in older adults, and social isolation itself is a risk factor for abuse. Again, potentially, PDs predict involvement in negative relationships. A negative relationship with a caregiver is a risk factor for abuse. And oddly, one of the main findings is PD might affect older adults in sort of a reverse way, where it is the presence of a personality disorder in one of their caregivers that may be the more important predictor of them being abused. So because personality disorder predicts lower income, the financial dependence of a caregiver on the person they care for is a risk factor for abuse. Okay, so non-personality disordered older adults who have a personality disordered caregiver, maybe a child or a niece or a nephew or a spouse who has a personality disorder, and if that person is financially dependent on the older adult, they are at a high risk for abuse. And again, PDs predict the experience of drug and alcohol problems. The drug and alcohol problems of caregivers is a strong predictor of abuse. Do older personality disordered adults have an increased risk of suffering comorbid health problems? Probably. Personality problems identified during early adolescence have been found to predict ongoing medical problems over a 20-year follow-up period. Yes, borderline PD is related to increased risk for obesity and diabetes. Yes, schizoid, avoidant, and obsessive compulsive personalities are associated with increased risk for coronary heart disease. Yes, statistically, people with personality disorders consume more healthcare resources in both the mental and physical healthcare sectors than do people without personality disorders. Do older personality disordered adults have an increased risk of experiencing adverse life events? Yes, it's associated with increased hospitalizations, more frequent interpersonal conflict, social isolation, abuse, and health problems. Yes, older adults with antisocial personality have an increased risk of death and incarcerations, or in the case of severe antisocial PD, the person may already be incarcerated. But more importantly, older adults with PDs will certainly face adverse life events the same as do younger people. So on average, people with personality disorders are going to face the same crappy things that happen in life that the rest of us face, like the deaths of loved ones, illness, and so on. However, they're at increased of risk of the adverse effects of these things because they already are starting from a position of having a diminished ability to cope with these life events, and also are probably or have an increased risk of social isolation, and so do not have a support network, again, to help them deal with these things. All right, maybe make it a little more fun now, I hope. Let's see. Part 3, detecting a personality disorder. So we're not going to talk about diagnosing a personality disorder per se. We're trying to make it a little more practical than that. So in your work as a clinician, when you encounter people on a daily basis, how do you detect that there might be a personality disorder going on? So what are some interpersonal clues? So these are just clues. These are not diagnostic. They don't mean that someone has personality disorder. They might just tip you off. And the more of them a person sort of checks off, maybe the probability increases. So the person is frequently in conflict. So you hear these things from these people all the time. I gave the cleaning staff a piece of my mind. My sister and I are not speaking again this week. I only get along with a couple of the nurses in this place, right? So if you've worked in long-term care or worked with people in inpatient or outpatient settings, you hear people expressing this. Everything is defined in their life as conflict with other people. The person is oddly socially isolated. So what do I mean by oddly? Well, for example, the person's socially isolated and lonely, yet there is family living nearby. So, you might ask them, how come your kids don't visit? Why don't you see them more often? And they might not have a good answer for that, but it might be the case that if they have a personality disorder, that they push these people away, they've become estranged. Or the person is socially isolated, but is not lonely. Families say they do not feel welcome to visit. So either the person is maybe antisocial to an extent that other people don't want to visit them, or the person is like high on a dimension of detachment and therefore do not want people to visit. They don't feel lonely, and so on. More interpersonal clues. The person is overly boastful. Okay? So I've heard these things from clients before. You need to know about all my past achievements in order to understand me. Or I am complex, no one really understands me. Or my ideas are ahead of our time. I'm not sure you have the required education or training to help me. I've heard all of these. I've even had people ask me or hand me over a stack of their diaries or journals and tell me that before I can even really start to grasp them or understand them, I really should read their journals or this book that they wrote. The person is overly familiar. They call their doctors by their first names and speak about them like they are friends. They might ask you a lot of questions about your personal life. The person describes other people in all or nothing terms. So people are either amazing or they are horrible. I loved my last social worker. He was absolutely amazing. And maybe you're a social worker and they're already contrasting you to this last social worker. Or my last physiotherapist did absolutely nothing for me. Okay, so it's all or nothing. The person is overly dramatic. They speak and act like they're on stage. Tears flow easily. The person displays rapid shifts in mood. So they shift between despair and happiness quite easily and quickly, or between apparent panic to calmness. They repeatedly make mountains out of molehills. So everything is a crisis. Right? You might have had a client before that leaves you multiple or repeated phone messages to inform you of the emergency that's going on in their life, only to discover later it's nothing. It's nothing big. The person is overly and persistently negative about other people. So the cleaning staff always screws up my linens. The kitchen staff here couldn't cook if their life depended on it. No one around here knows what they are doing. So they're not necessarily fighting with these people, but they just have a persistently negative outlook of other people. The person is overly self-negative. So, and in the absence of clear signs of depression. So of course, depression is characterized by intense self-negativity, but in this case, you don't really get a flavor for depression, but they express a lot of self-negativity. So you should forget about me, you're just wasting your time, I'm useless, or I will not be able to do it. You might see this in people who are dependent or people who are avoidant. The person expresses a great deal of distrust of others. So the woman across the hall gossips about me. My neighbor is always watching to see who comes to visit me. I think the building manager is trying to get me kicked out of the building. Right, so paranoid personalities will say things like this. The person externalizes the causes of the problems in their life. So my wife always, or my husband never. I've heard those a million times. The stupid worker didn't remind me to get my medications refilled, right? So even when the person could have had some self-control or had some responsibility of their own and something goes wrong, they place the blame someplace else. Yes, I ran the stop sign, but that idiot should have stopped before hitting me. Okay, the person is non-compliant with treatment. They sign themselves out of care, refuse care if their demands are not met. The person is constantly seeking reassurance over small things. The person frequently expresses concern that their treating professionals dislike them or will abandon them. I am impossible to help. You will probably just give up. You must find me so annoying. The person repeatedly discusses slights and grudges going back many years, even decades. This one here example is true. I saw a lady over 10 years ago now who had this story. You know, I was wrongly fired from my job at a store 30 years ago. Here, I'll show you a copy of the letter I wrote to the manager. She had a stack of letters that she had written to politicians and to her manager, complaining about how she'd been wrongly fired from the job. And she was still upset about it. When she talked about it, you know, at the time, she was still angered by it. The person makes excessive and unrealistic demands. Can't you call me every day? The person is persistent, yes, no client. So yes, I will get out for a short walk every day. That's a great idea. Then you see them a week later and they say, no, I didn't walk even once since we last met. I don't like walking, right? So there's like a passivity there. Or the person is a persistent no client. So they ask for help but refuse everything. So no, meds will not work for me. Or no, I don't think I need to exercise more. No, those mindfulness techniques won't work. No matter what you propose to them, it won't work for them. But if you suggest that you discharge them, then they're upset that you are doing nothing to help them. So what are some life history clues? History of self-harm, never married, or at least like no significant long-term relationships, or many marriages or past relationships, often described as stormy, past contacts with law enforcement, they are estranged from family, many short-term hospitalizations, a history of treatment-resistant mood or anxiety disorders, right? We see this all the time. I've tried just about every kind of antidepressant and nothing works. Okay, so again, detecting a personality disorder. So I propose that, yeah, maybe you can feel a personality disorder because we're all human, right? And we all exist somewhere on these traits, the 5 traits that we talked about. And so when people are extreme and rigid on these traits, you will feel a pull, right? That's an old sort of interpersonal sort of theory idea that people pull or evoke responses from us. Okay? It's literally the saying of, if you smile at the world smiles back, right? Well, personality disorder people don't smile at the world, right? So they don't pull good feelings from other people. So maybe you can feel when a person is disordered. So the person rubs you the wrong way or gets under your skin. Or when interacting with them, you find yourself wishing they would stop talking, right? It sounds horrible, but as clinicians and so on, we're people too. And so while we hopefully behave professionally, these feelings that we feel inside are clues to us as to what's going on, and we can't help these automatic feelings. So you might literally be talking to someone and thinking, I wish you would shut up, you know, for lack of a better phrase. You don't say it. You hope you don't say it. Okay. Even after just a few visits, you begin to dread visiting this person. Or you procrastinate calling them and dread calling them. Maybe you start calling them on Friday afternoon and hope they don't answer so you can leave a message, right? Because they wear us down. It's punishing. So it's difficult. Okay, so again, what else do they pull and evoke? Maybe you roll your eyes. So, you should be self-examining right now and say, yeah, I've done that. I've been on the phone with someone and I'm rolling my eyes. This is a sign. These are signs that you could be dealing with a personality disorder. You have to work hard not to roll your eyes when you're face-to-face with them. You hang up the phone or walk out of their room and mutter some curses, right? Again, hopefully you'd never say it to their face, but when a person's pulling that hard or when you've been dealing with them long enough, they wear you down. They try to make you feel guilty, but you just feel angry, right? You haven't called in 2 days. I thought you forgot about me. We've all heard that. Interacting with them makes you feel angry. All right, so we're going to hold that angry thought in your mind, because we've really badmouthed us here. Like we're saying, these people really pull sort of the worst from us. So how do we manage that? So why might we experience this anger? Why might we experience anger in response to personality disordered people, but not to our clients that have dementia or have a brain injury? Well, there's a lack of forgiveness. It's unfortunate and it happens automatically, but we tend to overestimate the degree of control that personality disordered people have over their behavior. So we tend to experience their actions, their behaviors as intentional, and as a result, we feel anger. Okay, it happens quickly and automatically. Conversely, we more easily recognize that our clients who have brain injuries or dementia lack control over their behavior. And so consequently, we forgive their difficult behaviors. Again, it happens automatically. There's a mitigating circumstance. We see that they are not well, and so they get forgiven. We might experience temporary frustration with those clients, but it rarely turns into anger. So how can we manage that anger, right? We have to try to remain professional. We can roll our eyes when we hang up the phone, but we shouldn't roll our eyes when we're talking to them in person. So here's some things you can do. Constantly remind yourself that despite appearances, these people do fundamentally lack insight and control over their behavior. They can learn it through therapy, but when we're first discovering these people, they often fundamentally just lack that insight and control. They do not intend to make you feel angry. Remind yourself that they evoke anger and frustration from most people they encounter. And so you should not be just another one of those people. You are a trained professional. Do not take it personally. And remind yourself that they are suffering too, okay? Try to convert your anger into compassion. No one would choose the loneliness, anxiety, depression, and emotional volatility that they are experiencing. Okay, so try to have compassion. Own it, own your anger, be mindful. So do not feel guilty about your anger, just accept it as a normal human emotional response to a difficult situation. So I feel angry after I talk to that person, but that's okay. They do behave in frustrating ways. I'm entitled to feel angry, but I'm not entitled to act on it. Forget about it, okay? Easier said than done, but actively give your permission to forget about a challenging client when you're not engaged with them. The less you think about them when you're not engaged in their care, the longer and better you will actually be able to care for them. So by forgetting about them on the weekends or every evening, you won't burn out as quickly. You'll be able to help them longer. So forgetting about them, you're actually doing them a favor. Constructive venting, discuss the client with a coworker for ideas, or at the least to feel heard and to validity check. Okay, my client makes me feel so frustrated and angry. Am I crazy? Am I blowing this out of proportion? Do you have any tough clients like this? What would you do? So consult with others. Just venting it alone can help. Establish boundaries. So as soon as you notice that a client's pulling or evoking frustration and anger from you, you need to establish clear boundaries. You cannot grant every request. Okay. Got to move a little quicker here. I've only got about 2 minutes left to talk. So I'll call you Thursday or Friday next week. So don't be concerned if I don't call before then. So you're setting limits all the time. So when I call or visit next week, we will have 30 minutes. So put that expectation in their mind, because some of these people, they'll keep you around forever and you can't give into that. So if you walk into a meeting putting a limit on it, saying, I've got 30 minutes for you today, Jim, then at the 30-minute mark, you can say, oh, look what time it is. Gosh, time flew, Jim. I really have to get going. It just seems less like you're leaving out of annoyance, as opposed to, I'm leaving, Jim, because I had to. Okay. No, sorry, I cannot call your family doctor to ask that they change your medications. You should discuss it with her at your appointment next week. Again, we can't give in to every request. Establish clear treatment goals. So be repeatedly clear with the client about what your role in their care is. Okay. So I'm here to find out what activities you might enjoy or what community agencies you might need to be connected with. So this is my role. Okay. It is my job to help you come up with an exercise program, and not much more beyond that. Pre-planning. So anticipate the fact that a particular client is difficult to work with and plan accordingly. Right? So if a client makes you feel angry and you're worried you might respond to them with anger, then perhaps see them earlier in the day or when you're your most patient and most rested. Or if they make you feel angry and you're starting to worry about how you're responding to them, then maybe see them near the end of the day or at the end of the week when you can feel the anger and have a break immediately afterward. Okay. Inoculate yourself. That sounds weird, but go into each engagement with that person having already told yourself, this person frustrates me, but that is okay. I'll have this meeting with them and I will be patient and compassionate and refuse to let myself respond with any angry behaviors. I hate driving. I hate driving around town. I go nuts. And so now I get in my truck and I say to myself, I'm going to drive slowly home. I'm going to just focus on the radio. I am not going to get angry at other drivers. I'm like inoculating myself against that. And it works even with clients. Okay? Be a passive participant. Do not become their ally in a fight against others. If a client repeatedly tries to engage you on topics about other people, like my stupid sister, my crazy neighbor, my crappy doctor, you can listen, but do not agree with them. Simply deflect or provide gentle alternative explanations. So really, your sister said that. I wonder if she's just frustrated or tired because as you told me, she's been dealing with a lot of health issues lately. Like, try to give them those alternative explanations. But it's not even probably useful to argue, but don't agree with them either. You don't want to be just like everyone else in their life. Oh, that's it. Good. Okay. All right, so we've got a few minutes left. If anyone has any questions or comments, some people might have good ideas about boundary setting, things that they've used in the past or techniques they've used to help them deal with the frustration or anger that a client has evoked or pulled from them. So I'd like to hear those.
Dr. St. Pierre, we do have a question, and thank you, Marilyn, for being patient. We waited till the end, and the question is there an association with PTSD, post-traumatic stress disorder, and personality disorders?
I don't know if not a persistent or strong association necessarily, but I would argue that I don't know for sure. I don't know the research, but I just hypothesizing that I would think that people who are maybe in that anxious avoidant sort of cluster of personalities might be more prone to developing a PTSD in response to a traumatic event. Because again, remember I talked about those people with PDs face the same adverse life sort of situations that the rest of us face, but they will have a diminished capacity to deal with it because they're not starting at the same baseline that everyone else is starting at. So when they face a traumatizing circumstance, they've already got a diminished capacity to sort of cope or adjust to it. And so they are probably at increased risk of that sort of acute stress developing into a more chronic state like a post-traumatic stress disorder. I'm sort of I hope that's an educated guess, but I'd put my money on it.
The chat is open, folks, if people wish to put questions in the chat. I also have another question from Marilyn. What approaches would you use with a resident with personality disorder is aggressive towards other residents with dementia, i.e. intentionally picking on vulnerable residents with intent to harm, for example, spilling coffee in front of someone, hoping they will fall? Ooh.
Yeah. Oh God. That's a tough one. I don't know. Because like if that is like literally a true scenario, then obviously those other patients have to be protected from that person, right? Like, so that would be mission one, is making sure those people are protected. How do you literally treat the person who's committing the acts? I don't know. We can't punish, right? So maybe that person's bored. I don't know. So finding them meaningful activities to engage in. Again, is the person doing it purely? If they are in the same facility as people with dementia and so on, then you also have to question, all right, does this person who has some sort of problematic personality traits, are those traits even being worsened or exacerbated by maybe their own cognitive impairment? And so you have to deal with that probably first, or address that. And so there might be very little hope in educating them But I guess if you found them some meaningful activities on a daily basis that literally keep them preoccupied and they're not bored, they might pick on others less. Even I'm unsatisfied with that answer, but it's probably the best I can do. Sorry.
No, I think that makes sense. As the approach certainly resonates for those of us that work with people with dementia. Any other questions, folks?
It's Ruth. I have a question for you, Dr. St. Pierre. I was curious at the beginning of the presentation, you talked about individuals who are affected by their caregivers and their care partners who are presenting with a personality disorder. How do you incorporate, or how do you, we as care partners or as care partners work with this? Like, do you provide information to them? Do you bring them into the sessions, or?
Okay. So do you mean in the case when I discussed the fact that people with a personality disordered caregiver would be at increased risk of abuse?
Yeah.
Yeah. Okay. Yeah. I don't know, but yes, usually that abuse has to be identified and obviously ended. Well, probably the most important thing is that the personality disordered caregiver has to get into treatment.
Okay.
I'm not convinced that some sort of group or like a couples or anything like that therapy is going to work, because again, chances are that the highest probability here is that the person being cared for might have cognitive impairments and so on, and so engaging them in some sort of corrective therapy is probably not going to have much effect. So you have to target that actual caregiver.
Okay.
If you were maybe referring a little more even to I talked about the fact that sometimes people live with subclinical or subclinical levels of a PD trait, and then they lose a stabilizing force in their life, like a caregiver, like a healthy, positive caregiver, then all of a sudden their personality gets worse. Yeah, in that case too, it's trying to reestablish those stabilizing factors, I guess. Yeah.
We have another question in the chat, and then we'll go to Heather Woodbeck. So the question in the chat is, can you explain the correlation between childhood trauma and personality disorders, especially BPD? Yeah, again, my last understanding of the research was I believe there's some estimate as high as 30%, and I could be wrong, but I think it's as high as 30% of women who present with a borderline personality disorder have experienced some sort of early life trauma, often sexual trauma or severe abuse. So there's some early implications here of like attachment disorders and things like that. Because again, to oversimplify, we should think of personality as essentially the product of an interaction between our inborn temperament and our environmental experiences. So we're all, we can even see individual differences in babies, right? Some babies are more fussy than other babies and so on. Some babies sleep better than other babies. So this is sort of these inborn temperament things, like how patient is the baby? Is the baby easily frustrated? So that then interacts with our environmental experience. So this baby that is born very easily frustrated and so on, then unfortunately maybe faces some early life traumas or early life abuse, they are now at really high risk of developing a personality disorder. Like I'm oversimplifying. Whereas maybe another baby faces some early life. Another baby is also just as easily frustrated as a child, but is just very fortunate to grow up in a very stable and a very stable and emotionally healthy home, and that person might have some traits later in age, but they're very minimal and non-problematic. So Thank you, Heather. We'll go to Heather.
Yeah, sorry.
Oh, hi, sorry.
Hi.
But this has been a really interesting discussion or presentation, and I think it's a very under-recognized issue in long-term care. But as somebody said before, there's a fair number of people in long-term care with personality disorders that are not diagnosed. That scenario that was shared of targeting another resident, I've heard that many times. I mean, I've worked for several years now with multiple homes in the sector, so that's where my perspective comes from. So my question is this: what can we do to help support the long-term care homes now that are dealing with these people? Because you can't really turf them out. And your point that the sort of congregate living setting could be making it worse just really resonated with me. I could so see it, like somebody not really liking to be around other people, and now they're stuck eating at lunch or dinner and breakfast with someone. Anyway, so what can we put in place locally, or what is in place? Thanks, to help.
I wonder if anyone else could answer that. I'm not sure what is in place. I unfortunately don't do much work in the long-term care homes. Ideally, wouldn't it be great if we could do some kind of personality assessment, like almost like matchmaking.com type idea, and put and set up people with like a roommate who is similar to them in personality, or have all people with schizoid personalities on one unit, and they don't have to talk to each other, and otherwise, yeah. But I wonder if anyone else can jump in and say like what is in place. I
So
can't
some of
really...
the comments, Dr. St. Pierre, is education being really important. Having good understanding. Comment about Behavioural Supports Ontario staff. Of course, I would do a shout out to that as well. Again, still a lot of talk about education, education for staff. There's also another comment saying from Laurie McDonald saying, I feel it's also important to ensure the team feels comfortable using consistent approaches to the individual. This will help limit setting for the person and will help the team to feel and function better. Yes, for sure.
Yeah.
So we are right at 4 o'clock. I know there was one more question from Marilyn. So I think we'll have Dr. St. Pierre comment about that and provide that in our when we send out the link to this presentation. So again, if anyone has a quick question they want to add to the chat, go ahead. But I'm going to take this time to thank Dr. St. Pierre for his time today. It was fantastic as always. And I know it was very informative, and I'm sure there was definitely some takeaways from everyone. And I kind of would smile and giggle because sometimes some of those examples of people who may have personality disorders, you can kind of think of someone in your family, someone that's close to you.
Yeah.
So yeah, thank you very much. And to, on behalf of the Centre for Education on Aging and Research, the Northwestern Ontario, Behavioural Supports Ontario, and St. Joseph's Care Group, just want to thank you, Dr. St. Pierre, and everyone for joining us today.
Thank you.
Goodbye.
Thanks.
Thank you very much. I think more to come, and possibly additional asks, Dr. St. Pierre, but thank you.
And just a reminder to the folks if you're still on, to please complete the poll. I saw it pop up earlier, and then again added to the chat if there's any other topic you'd like to see in the future.
Good. Thank you.